Vascular lesions of the gastrointestinal tract. Joanne Kwa, Lawrence J. Brandt. 38 Vascular lesions and disorders of the GI tract are being more accurately documented as our diagnostic modalities become more sophisticated. Among the diagnostic techniques commonly used today are upper and lower tract endoscopy, single and double balloon enteroscopy, SBE and DBE, video capsule endoscopy, VCE, and advanced radiologic imaging techniques, such as CTA and MRA. Vascular lesions are a common cause of GI hemorrhage and may be solitary or multiple, benign or malignant, isolated, grouped, or diffuse, part of a syndrome or systemic disorder, or due to an anatomic abnormality of the vasculature, or develop as a result of treatment. It is important at the outset to understand the nomenclature of vascular lesions. Vas and its derivative vascular are Latin words meaning vessel. The Greek equivalent is angion. Ectasia is a word of Greek derivation that refers to the process whereby a blood vessel becomes dilated or lengthened. The resulting lesion also can be referred to as an ectasia. Telangiectasia is the lesion that results from dilatation of the terminal aspect, tela, of a vessel. Angiodysplasia is used as a general term to describe the lesion or process whereby abnormally formed, bad, placis, molded, vessel develops. An arteriovenous malformation, AVM, is a congenital lesion, whereas an angioma is a neoplasm. This chapter discusses the clinically important vascular lesions of the GI tract, most of which cause GI bleeding. Primary vascular lesions. Colonic angioectasia AE of the colon is a distinct clinical and pathologic entity. 1-3 It is the most common vascular abnormality of the GI tract and probably the most frequent cause of recurrent or chronic lower intestinal bleeding in persons older than 60 years of age. 4 Es are acquired with aging, and there does not appear to be a gender predominance. In contrast to congenital or neoplastic vascular lesions of the GI tract, acquired Es are not associated with lesions of the skin or other viscera, although some 10% of patients with colonic AE have similar lesions in the small intestine when evaluated by angiography or enteroscopy. 3, 5, 6 Es almost always are confined to the cecum or ascending colon, often are multiple rather than single, and usually are smaller than 10 mm in diameter. They are seldom identified by the surgeon at operation or by the pathologist using standard histologic techniques, but usually they can be diagnosed by angiography, discussed later, colonoscopy, Figs 38.1 and 38.2, or helical CTA. 7 The roles of CT and MRI for vascular lesions of all types are evolving but are certain to increase as these sophisticated modes of diagnosis become more widely available. It is also clear that conventional angiography now is more important for therapy than for diagnosis. To determine the precise nature of a vascular lesion, histologic examination, with or without injection studies of the vasculature, is necessary. For example, in one publication in which histologic confirmation of vascular lesions was not performed, Es reportedly occurred distal to the hepatic flexure in 46% of patients. 8. Subsequent review of tissue sections from the supposed Es in the small bowel or left colon revealed histologic changes different from those of Es in the right colon. Personal review by S.J. Boley and L.J. Brandt. Pathology. Histologic identification of Es is difficult unless special techniques are used. 1 Although usually less than 1/3 of lesions are found by routine pathologic examination, almost all can be identified by injecting the colonic vasculature with silicone rubber, dehydrating the cells with increasing concentrations of ethyl alcohol, clearing the specimen by immersing it for 24 hours in a bath of methyl salicylate, and then viewing the specimen by dissecting stereomicroscopy. Fig. 38.3.1 In a study using these methods, surgically resected colons were found to have one or more mucosal Es that measured 1 to 10 mm in diameter. Es were usually multiple, and all were located in the cecum and ascending colon. 1 Microscopically, mucosal Es consist of ectatic, distorted, thin-walled venules, capillaries, and arterioles. The earliest abnormality is the presence of dilated, tortuous, submucosal veins, Fig. 38.4a, often in areas where overlying mucosal vessels appear normal. More advanced lesions show increasing numbers of dilated and deformed vessels traversing the muscularis mucosa and involving the mucosa, see Fig 38.4b and c, until, in the most severe lesions, the mucosa is replaced by a maze of distorted, dilated vascular channels, see Fig 38.4d. Enlarged arteries and thick-walled veins occasionally are seen in advanced lesions, in which the dilated arteriolar capillary venula unit has become a small arteriovenous AV, fistula because of loss of prearteriolar sphincter function. Large thick-walled arteries, however, are more typical of congenital AVMs. Pathogenesis. The previously described studies using injection and clearing techniques indicated that Es are acquired with aging and that they represent a unique clinical and pathologic entity. 1 Clinically, Es are frequently identified at colonoscopy in older adults and in injected colons resected from older patients with no history of bleeding. 9 Bowley postulated that the likely cause of Es is partial, intermittent, low-grade obstruction of submucosal veins at the site where these vessels pierce the muscular layers of the colon, Figs 38.5 and 38.6.1. He then went on to propose a schema for their development, suggesting that repeated episodes of transiently elevated pressure during muscular contraction and distension of the cecum over many years result in dilatation and tortuosity of the submucosal vein and, later, of the venules and capillaries of the mucosal units that drain into it. He further suggested that, ultimately, the capillary rings dilate, the precapillary sphincters lose their competency, and a small AV fistula is produced. The latter is responsible for the early filling vein, which was the original angiographic hallmark of this lesion, Fig 38.7. Prolonged increased flow through the AV fistula can then produce alterations in the arteries supplying the area and in the extramural veins that drain it. This developmental concept of the cause of Es was based on the finding of 1. A prominent submucosal vein, either in the absence of any mucosal lesion, or underlying only a minute mucosal AE supplied by a normal artery. 2. Dilatation of the veins, starting where they traverse the muscularis propria, see Fig 38.5, and 3. Previous studies showing that venous flow in the bowel may be diminished by increases in colon motility, intramural tension, and intraluminal pressure. 10 Following this logic, the prevalence of Es in the right colon can be attributed to the greater tension in the cecal wall compared with that in other parts of the colon, according to Laplace's principle, TPR, where T is tension, P is intraluminal pressure, and R is radius. An alternative concept for the development of Es is based on the demonstration that Es have been shown to express vascular endothelial growth factor, VEGF, and its receptors along their endothelial lining in surgical specimens from patients who have undergone colectomy for recurrent bleeding. 11. This indicates a proliferative phase of angiogenesis. VEGF and VEGF receptor 1 have been shown to be upregulated by hypoxia. 12 And therefore a role also has been suggested for hypoxia in the pathogenesis of Es. It further has been proposed that von Willebrand factor, VWF, regulates angiogenesis through multiple cross-talking pathways that involve VEGF receptor 2 signaling, angiopoietins, and integrin alpha-nu beta 3. In a mouse model, inhibition of VWF in endothelial cells results in increased in vitro angiogenesis and increased VEGF receptor proliferation and migration, coupled to decreased integrin alpha-nu beta 3 levels and increased angiopoietin release. 13 Further research still is needed to clarify the pathophysiology of Es. Clinical features and associated conditions. In 1961, Baum and colleagues used intraoperative angiography to show that cecal Es may bleed. 8 Today such an observation is well documented in daily practice by colonoscopy. Recent publications have cited Es and diverticulosis to be responsible for 3%. Fig 38.1 Endoscopic image of an AE in the ascending colon. This AE has a typical coral reef-like pattern of small vessels distorting the mucosa and submucosa. A tortuous submucosal vein, which is the earliest stage in the development of an AE, probably is present among the linear vessels intersecting the ectasia but cannot be distinguished. Fig 38.2 Endoscopic images of multiple Es in the ascending colon of an older adult patient who presented with recurrent bouts of LGIB. Es can be single or, as shown here, multiple and of various shapes and sizes. Draining veins are seen adjacent to the E's. Chapter 38 Vascular lesions of the gastrointestinal tract 563-38 ABC Fig 38.3a. A specimen of resected colon that has been injected with silicone rubber but not cleared. See text for details. Stereomicroscopy reveals the honeycomb-like pattern of normal colon crypts. B. Coral reef appearance of an AE in an injected, but not cleared, colon. The normal crypts are seen surrounding the AE. C. Injected, cleared, and trans-illuminated colon showing a mucosal ectasia surrounded by normal crypts with ectatic venules leading to a large, distended, tortuous underlying submucosal vein. A and B, from Mitsudo S., Boli S.J., Brandt L.J., ETAL vascular ectasias of the right colon in the elderly, a distinct clinical entity. Humpathol 1979, 10:589, C., from Boli S.J., Sammartano R.J., Adams A., et.al. On the nature and etiology of vascular ectasias of the colon, degenerative lesions of aging. Gastroenterology 1977, 72:650-60, with permission. ABCD ectasias of the colon, degenerative lesions of aging. Gastroenterology 1977, 72:650-60, with permission. Vessels, H&E, times 50, from Boli S.J., Sammartano R.J., Adams A., et.al. On the nature and etiology of vascular biectatic vessels. Only one layer of endothelium separates the lumen of the cecum from those of the dilated ing and replacing the mucosa. D. A late stage of AE shows total disruption of the mucosa with replacement into the mucosa. C. A further stage in the development of an AE lesion in which the ectatic vessels are disrupt vessels is microfillar. B. A more advanced AE lesion in which dilated tortuous veins in the submucosa extend the overlying mucosa. This appearance is the hallmark of an early AE. The black material in the lumen of the Fig 38.4 histopathology of AE. A. Large distended veins filling the submucosa with a few dilated venules in 564 Part 4 topics involving multiple organs to 15% and 20% to 65%, respectively, of acute LGIB episodes, see chapters 20 and 121.14. The problem of attributing bleeding to one or the other cause, when bleeding from the lesion is not demonstrated by colonoscopy or by extravasation of contrast material on vascular imaging studies, is compounded by the frequency and coexistence of these disorders without bleeding in people older than 60 years of age. The prevalence of diverticulosis is estimated to be as high as 50% in the population older than age 60. Mucosal and submucosal E's of the right colon can be found by injection studies of colons removed at surgery in more than 25% and 50%, respectively, of patients in this age range without evidence of bleeding. 1.15 In large series of colonoscopic examinations, E's have been seen in 0.2% to 2.9% of non-bleeding persons and 2.6% to 6.2% of patients evaluated specifically for occult blood in the stool, anemia, or hemorrhage. 3,9,16 In a patient being studied for GI bleeding, in whom the site of active bleeding is unproven, the only basis for determining that an identified AE or diverticulum is responsible is the indirect evidence provided by the patient's course after ablation or resection of the suspected lesion. It is unusual for incidentally found E's to bleed, and an AE, even in a patient with a history of bleeding, cannot be assumed to be the cause. 17 Bleeding from E's typically is recurrent and low grade, although patients can present with massive hemorrhage. The nature and degree of bleeding frequently vary in the same patient with different episodes. Patients may have bright red blood, maroon stools, or melena on separate occasions. This spectrum reflects the varied rates of bleeding from the ectatic capillaries, venules, and AV communications, which depends on the developmental stage of the lesions. In one study, bleeding from E's was characterized by tarry stools in 20% to 25% of cases, whereas the minority, 10% to 15%, of patients exhibited solely iron deficiency anemia, with stools that were intermittently positive for occult blood. 4 Another study reported that EAS resulted in hemodynamically significant LGIB in 21% of cases, although 42% exhibited chronic LGIB or anemia without evidence of acute hemorrhage. 17 Today, EAS are thought to be asymptomatic or to result in occult obscure GI bleeding in most patients. Bleeding from EAS stops spontaneously in more than 90% of cases. In 1958, Haid described what is still a controversial association, AE, GI bleeding, and aortic stenosis, as aortic valve replacement, AVR, had even been recommended for Haid syndrome when bleeding could not be managed by medical means. Numerous reports of Haid syndrome appear in the literature, although some analyses 18 and studies 19 have failed to support the association. The existence of Haid syndrome has been suggested AGAIN20 in a retrospective study in which the frequency of AS was 31.7% in patients with AVMs compared with 14% in the general population. It has been postulated that deficiencies of the largest forms of VWF multimers, von Willebrand disease, type 2A, result in hemostatic abnormalities that may predispose pre-existing EAS to bleed. 21 It is now believed that increased shear stress results in unfolding of the globular Fig 38.5 vasorectum and accompanying vein traversing the cecal muscularis propria. Compression of the vein is the functional anatomic explanation for its intermittent, partial low-grade venous obstruction, elastinvangiocin, times 50. From Boli S.J., Sammartano R.J., Adams A., et.al. On the Nature and Etiology of Vascular Ectasias of the Colon, Degenerative Lesions of Aging. Gastroenterology 1977, 72:650-60, with permission. ABCDE of Aging. Gastroenterology 1977, 72:650-60, with permission. Martineau R.J., Adams A., et.al. On the Nature and Etiology of Vascular Ectasias of the Colon, Degenerative Lesions. The AE, this stage accounts for the early filling vein seen on mesenteric angiography. From Boli S.J., Samth precapillary sphincter becomes incompetent, and a small arteriovenous communication is present through into the abnormal submucosal vein becomes similarly involved. E. Ultimately, the capillary ring becomes dilated, that accounts for the slowly emptying vein on mesenteric angiography. D. Later, the veins and venules draining after repeated episodes over many years, the submucosal vein becomes dilated and tortuous, this is the stage Keeler layers. B. With muscular contraction or increased intraluminal pressure, the vein is partially obstructed. C. Fig 38.6 Proposed concept of the development of cecal AE. A. Normal state of the vein perforating the Muse. Chapter 38 Vascular lesions of the gastrointestinal tract. 565-38 von Willebrand polymer into an elongated highly asymmetric protein, which exposes the A2 domain. 22 Atoms 13 then binds to the A2 domain, which results in cleavage of this high molecular weight multimer into smaller polymers, which are less hemostatic than their parent molecules. 22 Preoperative deficiency of these multimers reverses after AVR 23 with resolution of bleeding in most patients with Haid syndrome who underwent AVR. Recommendation to replace the aortic valve to control GI bleeding from EAS is controversial. 24 Currently AVR is only recommended for patients with severe AS and not for those with GI bleeding or iron deficiency anemia in the setting of asymptomatic AS because most bleeding from EAS can be controlled by any one or more of a variety of endoscopic techniques. See Chapter 20. GI bleeding is a major occurrence in those with a left ventricular assist device, LVAD, and now recognized to result most commonly from UGI tract angiodysplasia, discussed later. A recent meta-analysis of 17 case control and cohort studies showed a pooled prevalence of GI bleeding in continuous flow LVAD patients to be 23% with potential risk factors of older age and elevated creatinine. 25 The mechanism of LVAD-associated GI bleeding is still not well understood but has been attributed to impaired VWF-dependent primary hemostasis. 26 Such impairment may be a result of decreased specific activity of VWF, shear stress that results in release of preformed VWF from endothelial cells, and decreased high molecular weight multimers in non-pulsatile flow regimens leading to acquired von Willebrand syndrome. 25 It has been noted that wide pulse pressures are associated with increased von Willebrand multimers. 26 But that patients with LVADs and AS have narrow or zero pulse pressures. Studies are underway to determine whether decreasing the speed of these devices and hence inducing more pulsatile flow will result in a reduction in GI bleeding, although preliminary results do not show improvement in acquired von Willebrand syndrome with these maneuvers. Patel et al. Published a novel approach using nasal endoscopy to determine the risk of GI bleeding for patients with LVADs. The presence of nasal hypervascularity as a potential surrogate for GI vascular lesions helped determine the risk of GI bleeding in patients who were to undergo LVAD. They found that nasal hypervascularity was equally common in patients with heart failure regardless of whether or not they received an LVAD, 63% in the LVAD group and 57% in the heart failure group versus 20% in the control group, but there was a statistically significant association between GI bleeding in patients with LVAD and nasal hypervascularity with an incidence of 32%. There was no statistically significant association between GI bleeding and heart failure patients with hypervascularity but without an LVAD. Thus, nasal endoscopy may be a potential surrogate marker for GI mucosal vascular alterations. Further studies are being done to compare nasal endoscopy findings in LVAD patients with and without small bowel vascular lesions diagnosed by VCE to confirm this hypothesis. 27 Diagnosis and management. Management of colonic ease begins with suspecting the lesion in an older person who has acute or chronic LGIB. See Chapter 20. Colonoscopy is the primary means of both diagnosis and treatment. If the suspected lesion cannot be found, or if bleeding is massive and colonoscopy cannot be performed, radionuclide scintigraphy followed by CTA should be performed. One retrospective study compared CTA to 99 mTC labeled red blood cell scintigraphy, RBCs, for the overall evaluation and management of acute LGIB and found that both CTA and RBCs could be used to identify active bleeding, 38% of cases, but the site of bleeding was localized with CTA in a significantly higher proportion of studies. Of 24 patients in whom the site of LGIB was accurately localized by CTA, 2 patients were diagnosed with AVMs. RBCs did not establish causation of bleeding in any patient. 7 The endoscopist's ability to diagnose the specific nature of a vascular lesion is limited by the similar appearance of different types of lesions. EAS, spider angiomas, telangiectasias, angiomas, the focal hypervascularity of radiation colitis, UC, Crohn's disease, ischemic colitis, certain infections, hyperplastic and adenomatous polyps, and malignancies, including lymphoma and leukemic infiltrations, can all, on occasion, resemble each other. Box 38.1. Because traumatic and endoscopic suction artifacts may resemble vascular lesions, all lesions must be evaluated on insertion of the colonoscope, rather than during withdrawal. Pinch biopsy samples obtained from small, non-elevated vascular lesions during endoscopy usually are nonspecific, therefore, the risk of performing biopsies of these abnormalities is not justified. Sometimes the prominent feeding vessel of an AE might be appreciated at the time of endoscopy, and the mucosa at the AE margin may be more pale than distant mucosa, although such a pale halo also may be seen in other vascular lesions. 28 Because the appearance of vascular lesions is influenced by a patient's blood pressure and blood volume, such lesions may not be evident in those with significant anemia or hypotension, thus, accurate evaluation may not be possible until red cell and volume deficits are corrected. Meperidine also may diminish the prominence of finer vascular abnormalities, e.g., EAS, the telangiectasias of HHT. Use of meperidine, therefore, should be AB Fig 38.7 Angiography of AE. A. Superior mesenteric artery arteriogram from a patient with EAS shows 2 densely opacified, slowly emptying, dilated tortuous cecal veins, arrows. Note the late visualization of the ileocolic vein after the other veins have cleared. B. Arterial phase of the same arteriogram shows 2 vascular tufts, thick arrows, and 2 early filling veins, each shown by a pair of thin arrows. From Boli S.J., Sprayregan S., Sammartano R.J., et al. The pathophysiologic basis for the angiographic signs of vascular ectasias of the colon. Radiology 1977, 125:6-1521, with permission. 566 Part 4 Topics involving multiple organs avoided and, if used, its effects reversed by naloxone so that vascular lesions can be detected accurately. Such a masking effect does not occur with fentanyl. 29 In patients who have received meperidine, naloxone has been shown to enhance the appearance of normal colonic vasculature in approximately 10% of patients and to cause existing ease to appear, 2.7%, or increase in size, 5.4%. Fig 38.8.30 For these reasons, naloxone is an important adjunctive medication for patients undergoing endoscopic evaluation for lower intestinal bleeding and who have received meperidine. Cool water lavage, to cleanse the mucosal surface during colonoscopy, also may cause underlying ease to vasoconstrict and disappear transiently. 31 Angiography is used to determine the site and nature of vascular lesions during active bleeding and can identify some vascular lesions even after bleeding has ceased. The three reliable angiographic signs of ease are a densely opaque epheid, slowly emptying, dilated, tortuous vein, a vascular tuft, and an early filling vein. See Fig 38.7. 32 A fourth sign, extravasation of contrast material, identifies the site of bleeding when the rate of bleeding is at least 0.5 ml/min but is not specific for AE. The slowly emptying vein, see Fig 38.7a, persists late into the venous phase, after the other mesenteric veins have emptied. Vascular tufts, see Fig 38.7b, are created by the ectatic venules that join the mucosal component of the AE and its submucosal vein. They are seen best in the arterial phase, are usually located at the termination of a branch of the ileocolic artery, appear as small candelabra-like or oval clusters of vessels, and still are seen in the venous phase communicating with a dilated, tortuous, intramural vein. The early filling vein is seen in the arterial phase within 4 or 5 seconds of injection, see Fig 38.7b, but is not a valid sign of AE if vasodilators such as papaverine or tolazoline, priscaline, have been used to enhance the study. When the lesion is bleeding, intraluminal extravasation of contrast material usually appears during the arterial phase and persists throughout the study. Extravasation identifies a site of active bleeding, but in the absence of other signs of ease, it suggests another cause for the bleeding. Management of non-bleeding ease incidentally found at colonoscopy is expectant. In such cases, endoscopic therapy is not indicated. 33 Because the risk of bleeding in asymptomatic patients with ease has been shown in a prospective study to be low, 0% in 3 years, 31 which clearly does not warrant the potential risks of bleeding and perforation with colonoscopic ablation. 1734-35 Bleeding from ease can be controlled endoscopically or angiographically in most patients, thereby avoiding the morbidity and mortality of emergency operation. Today, superselective microcoil embolization has replaced intra-arterial vasopressin infusion for the treatment of LGIB. Such embolization is highly effective and safe, although complications occur in 5% to 9% of cases. Serious complications, e.g., gangrene, hematoma formation, arterial dissection, thrombosis, pseudoaneurysm formation, are reported in less than 2% of cases. Vasopressin still is recommended, however, when intestinal vascular lesions are diffuse throughout the bowel or when superselective catheterization is not possible. 28 Hormonal therapy, using estrogens in combination with progestins, had been used to treat patients with a variety of bleeding vascular lesions of the GI tract. The mechanisms by which such agents work are not known, although procoagulant effects and enhanced endothelial integrity are popular theories. A long-term observational STUDY-36 showed that combination hormonal therapy stopped bleeding in patients with occult GI bleeding of obscure origin, likely to have resulted from angiodysplasias in the small intestine, although a recent meta-analysis detailed 2 case control studies in which hormonal therapy was ineffective for bleeding cessation. 37 It is conceivable that vascular lesions in the small intestine may respond differently to such treatment than similar appearing lesions in the colon. No study of hormonal therapy has been done for proven colonic ease. Somatostatin analogues are another option for the treatment of bleeding from GI vascular lesions. These agents work by inhibiting angiogenesis, decreasing splanchnic blood flow, increasing vascular resistance, and improving platelet aggregation. In the recent meta-analysis mentioned previously, 4 cohort studies were found assessing the efficacy of either daily or monthly octreotide. The pooled odds ratio for bleeding cessation was 14.5, 95% confidence interval CI, 5.9 to 36, and there was a decrease in transfusion requirements seen after 1 year of therapy with an odds ratio of 0.55, 95% CI, 0.29 to 0.82. 37 A novel therapy for ease, and perhaps other vascular lesions in the GI tract, is the use of anti-angiogenic factors, including thalidomide, bevacizumab, and lenalidomide. Thalidomide was developed in the 1950s as a sedative, sleeping pill, and antiemetic for pregnant women, but it soon became notorious for causing phocomelia and other malformations in the newborn. 37 In 1994, D'Amato and colleagues reported that thalidomide inhibited VEGF and basic fibroblast growth factor-mediated angiogenesis. 38-39 Data suggest the mechanism for its anti-angiogenic effect is related to reduced expression of integrin genes with resultant decreased cell-cell surface interactions and response to angiogenic cytokines. 40 Several case reports and case series have described the successful use of thalidomide to treat life-threatening or refractory bleeding from intestinal ease and Crohn's disease with refractory bleeding. 41-44 After treatment with thalidomide for 3 months, substantial reductions in the number, size, and color intensity of ease were documented by VCE. 42 A controlled trial of patients with GI angiodysplasias and gave, see later, randomized patients to thalidomide or iron supplementation and reported a 50% or greater decrease in bleeding episodes at the 1-year follow-up in 71.4% patients in the thalidomide group compared with 3.7% in the iron supplementation group. These patients had lesions that were predominantly confined to the stomach and small intestine, and there still is no experience with these treatments for colonic ease. 45 Box 381 Lesions that may be confused with AE on endoscopy. Colitis IBD infectious ischemic radiation neoplasms adenomatous polyps leukemic infiltration lymphoma non-neoplastic polyps hyperplastic lymphoid non-vascular lesions trauma vascular lesions angiomas anteriovenous malformations phlebectasias spider telangiectasias varices venous stars. Chapter 38 Vascular lesions of the gastrointestinal tract. 567 38 Bevacizumab, Avastin, is a humanized monoclonal antibody against VEGF that is effective against colon and renal cancers and also has strong anti-angiogenic activity. 46 Curiously, dose-dependent nasal and GI bleeding is observed in up to 59% of patients during treatment, possibly caused by a loss of vascular integrity as a result of bevacizumab-induced endothelial cell shedding in highly regenerative mucosal tissues with active angiogenesis. It is unclear why some anti-angiogenic substances like bevacizumab cause mucosal bleeding and others like thalidomide do not. This disparity effect may be related to the phase of angiogenesis that is antagonized or might reflect a particularly strong anti-angiogenic activity. Lenalidomide is a newer angiogenesis inhibitor that is an analog of thalidomide but with fewer adverse effects. Lenalidomide could present a new therapeutic asset for ease, although its role remains to be evaluated in controlled studies. 28 VEGF-based anti-angiogenic therapy is a promising therapy, but a more detailed understanding of the angiogenic cascade and how anti-angiogenic substances act within it will be needed to resolve this issue. In the past, neodymium yttrium aluminum garnet laser 3,6,47 endoscopic sclerosis 9 monopolar 48 and bipolar 49 electrocoagulation, and heater PROBE49 had been used to ablate a variety of vascular lesions throughout the GI tract and to control active bleeding. More recently, however, hemoclips in combination with cautery 50, endoscopic band ligation 51, and argon plasma coagulation, APC, 52 have been used for this purpose, Fig 38.9. 4Es, heater probe, and APC are most commonly used. Control of bleeding has been obtained with a variety of endoscopic thermal means in 47% to 88% of cases. 3 and no technique has been established as superior. 9 Severe delayed bleeding occurs in 5% of patients with colonic ease after thermal therapy. 48 Recurrent bleeding from colonic ease appears to be reduced after endoscopic therapies, but more than one treatment session may be necessary. 49 Rebleeding can be expected to increase with time and has been seen in 28% to 52% of patients over a follow-up period ranging from 15 to 36 months. 3 In preparation for endoscopic ablation of vascular lesions, aspirin and aspirin-containing drugs, other NSAIDs, anticoagulants, and antiplatelet agents should be withdrawn, if possible, at least several days before the procedure and depending on the agent. Aspiration of some intraluminal gas just before thermal therapy is applied adds a measure of safety as the colon wall is not so thinned with a smaller diameter lumen. Right hemicolectomy is indicated when AE has been identified by either colonoscopy or angiography and when therapy by either or both of these modalities is unsuccessful, cannot be performed, or is unavailable and the patient has continuous or recurrent LGI bleeding. The presence or absence of diverticulosis in the left colon does not alter the extent of colonic resection in this circumstance, only the right half of the colon is removed, but it is important that the entire right half of the colon be removed to ensure that no E's are left behind. If the site of bleeding, and its cause, is not identified, and bleeding recurs or is continuous, a subtotal colectomy, STC, is appropriate. Morbidity and mortality rates of an STC are not statistically different from those accompanying a blind hemicolectomy, i.e., when the bleeding site is not identified. 53,54 In one surgical review, mortality and rebleeding rates for STC, directed limited colectomy, and blind limited colectomy were 0% to 40% and 0% to 8%, 2% to 22% and 0% to 15%, and 20% to 57% and 35% to 75%, respectively. 53 Angiodysplasia. Angiodysplasias are most commonly found in the stomach and small intestine of patients with chronic kidney disease, see Chapter 37, but are also found in approximately 10% of patients with colonic ease. Other vascular lesions that occur in the small intestine include the blue rubber bleb, hemangioma, angioma, Tulafoy lesion, and portal hypertensive enteropathy, discussed later. Although SBE and DBE, Fig 38.10, are used for diagnosis and treatment of many of these lesions, VCE, Fig 38.11, is currently the mainstay for their diagnosis and for evaluating patients with obscure and occult GI bleeding because it is non-invasive, easily performed, and enables inspection of the entire small intestine. In a prospective multi-center study, VCE had an overall diagnostic yield of 67% for overt small bowel bleeding, with AE as the most commonly identified source. 55 Fig 38.8 Endoscopic images showing progressive changes in the appearance of a cecal AE after the administration of naloxone in a patient who had received meperidine sedation. Subtle at first, the AE becomes a pale and then deep red, fan-shaped obvious vascular lesion. From Brandt L.J., Spinel M. Ability of naloxone to enhance the colonoscopic appearance of normal color vasculature and colon vascular ectasias. Gastrointestinal Endosc 1999, 49:7983. BCDA 568 Part 4 Topics involving multiple organs. VCE also has been shown to be superior to push enteroscopy and small bowel series in a meta-analysis comparing these three techniques. VCE showed an incremental yield of 30% over push enteroscopy and 36% over small bowel series. 56 The diagnostic yield of VCE also has been demonstrated to exceed that of angiography, 53% versus 20%, in patients with acute overt obscure GI bleeding. 57 Vascular lesions are the most frequently identified culprit lesion in patients who undergo VCE for occult obscure GI bleeding. particularly those older than 65 years of age. 58 Younger patients tend to exhibit more sinister pathology, e.g., small intestinal tumors, as the cause of their anemia. 58 SBE and DBE can be used to examine the small intestine by either an anterograde or retrograde approach and allow for implementation of endoscopic therapy at the time of diagnosis. Video 38.1. The rate of complete enteroscopy has been reported as 57% for DBE compared with 0% for SBE, justifying a preferred use for DBE. 59 A meta-analysis of 10 studies comparing VCE and DBE in ABC Fig 38.9 endoscopic images showing AE and diverticulosis of the colon. A. Upper. A single AE nestled among diverticula in the ascending colon of an older adult man with LGIB. ES and diverticula are the two most common causes of major recurrent LGIB in older adults, therefore, finding them together in the same patient is not unusual. A. Lower. The AE after treatment with APCB, upper, multiple ES in the ascending colon. B. Lower. ES after treatment with a heater probe. C. Upper, a solitary AE. C. Lower. A heater probe is being used to ablate the AE. Fig 38.10 Angiodysplasia demonstrated by double balloon enteroscopy. Courtesy Dr. Daniel Mishkin, Boston, MA. Fig 38.11 Angiodysplasia demonstrated by VCE. Courtesy Dr. Daniel Mishkin, Boston, MA. Chapter 38 Vascular lesions of the gastrointestinal tract. 569 38 patients with obscure GI bleeding showed comparable diagnostic yields of 60% and 57%, respectively, although the diagnostic yield of DBE was significantly higher when performed after a positive VCE compared with a negative VCE, 75% versus 27.5%, p equals 0.02. 0.60. A recent study that investigated long-term outcomes in patients undergoing DBE for obscure GI bleeding identified small intestinal vascular lesions, i.e., angiodysplasias, telangiectasias, blue rubber blebs, and doulafoys, as suspected causes in 51% of patients. These lesions were successfully treated by APC in 97% of patients with a cumulative rebleeding rate of 46% at 36 months. 61 In a systematic review and meta-analysis, it was shown that approximately 34% of patients with angiodysplastic lesions and approximately 45% of patients with isolated small bowel angiodysplastic lesions rebleed after endoscopic therapy. 25 The meta-analysis also included 4 studies that looked at the impact of octreotide analogues on rebleeding rates for patients who were refractory to endoscopic therapy and showed a significant decrease in both rebleeding rates and transfusion requirements. The standard mean reduction in number of transfusions after 1 year of therapy was 0.55, 95% CI, 0.29 to 0.82. 2 studies analyzed the use of thalidomide for refractory bleeding, and both showed a decrease in rebleeding rates and transfusion requirements. 41,42 Doulafoy lesion. This vascular lesion is an unusual cause of massive GI hemorrhage and may occur anywhere in the GI tract from esophagus to rectum. Fig 38.12. 62 It is twice as common in men as in women and presents at a mean age of 52 years. The abnormality is the presence of an artery of persistently large caliber in the submucosa and, in some instances, the mucosa, typically with a small, overlying mucosal defect. Doulafoy called the lesion exulceratio simplex because he thought it was the initial stage of a gastric ulcer. This lesion also has been called an atherosclerotic aneurysm, an inaccurate term because the caliber of the artery's walls is uniform throughout and shows no unusual degree of arteriosclerosis. It is believed that focal pressure from these large caliber persistent vessels thins the overlying mucosa, leading to erosion of the exposed vascular wall with resultant hemorrhage. Massive hematemesis or melena typically is not preceded by any GI symptoms and usually is followed by intermittent and severe bleeding over several days. The most common site of bleeding is 6 cm distal to the cardioesophageal junction, where the arteries that supply the stomach are largest, but, as mentioned previously, Doulafoy lesions have been reported in extragastric locations, including the esophagus, small bowel, rectum 62 and even outside the GI tract in the bronchus. Endoscopically, a Dieulafoy lesion appears as an isolated protruding vessel surrounded by normal mucosa that may be difficult to find in a patient with UGI bleeding because the overlying mucosal defect may be small and hidden between the gastric rugae, and the caliber persistent vessel may constrict and retract after the bleeding episode. If found, tattooing of the lesion is advocated by some authorities to allow for rapid identification of the lesion should rebleeding occur. EUS also has been used to enhance detection of these aberrant submucosa vessels and can help determine whether endoscopic therapy was successful. Mesenteric angiography is used when endoscopy fails to localize a site of hemorrhage and may be of particular benefit in patients with lesions in the colon or rectum where the view could be obscured by active bleeding and poor bowel preparation. 63 Endoscopic techniques to localize and treat Dieulafoy lesions have decreased the need for surgical intervention and dramatically reduced the mortality of bleeding from 80% to 8%. Endoscopic treatments are considered safe and effective at achieving hemostasis with success rates reaching 75% to 100%. Therapeutic approaches to bleeding Dieulafoy lesions include injection therapy, heater probe, APC, band ligation, hemoclips, and the use of overthoscope clips. Combination endoscopic therapy with injection followed by thermal or mechanical therapy is superior to monotherapy and has achieved hemostasis in 95% of cases. 64 Rebleeding from these lesions is reported between 9% and 40%. 63 and is higher after endoscopic monotherapy compared with combination therapy. 65 Hemangioma considered by some to be true neoplasms. Hemangiomas generally are thought to be hamartomas. Hemangiomas are the second most common vascular lesion of the colon and may occur as solitary or multiple lesions limited to the colon or as part of diffuse GI or multi-system angiomatosis. Hemangiomas are structurally complicated lesions characterized by an excess of blood vessels, usually veins and capillaries, in a focal area of submucosal connective tissue. 66 Hemangiomas may be classified as cavernous, capillary, or mixed types. However, the most common hemangioma found in the GI tract is of the capillary variety. 66 Most hemangiomas are small, ranging from a few millimeters to 2 centimeters, but larger lesions occur, especially in the rectum. Bleeding from colonic hemangiomas usually is slow, producing occult AB Fig 38.12 endoscopic images of a Dieulafoy lesion. A. Arterial bleeding, spurting, just distal to the gastroesophageal junction. B. The bleeding point was a small defect without endoscopic evidence of ulceration. From Wilcox CM Atlas of Clinical Gastrointestinal Endoscopy. Philadelphia, W. B. Saunders, 1995, p. 122. 570 Part 4 Topics involving multiple organs. Blood loss with anemia or melena. Hematochezia is less common, except with large cavernous hemangiomas of the rectum, which may cause massive hemorrhage. The diagnosis is best established by endoscopy, including enteroscopy because radiologic studies, even including angiography, frequently are normal. The diagnosis of cavernous hemangioma of the rectum often can be suggested on plain films of the abdomen by the presence of phleboliths and displacement or distortion of the rectal air column, Fig 38.13. On barium enema, the affected rectal lumen typically shows narrowing and rigidity, scalloping of the rectal wall, and widening of the presacral space, see Fig 38.13. Endoscopically, one sees elevated plum-red nodules or vascular congestion. Ulcers and proctitis also may be present. Imaging with CT and MRI are highly accurate in delineating cavernous hemangiomas, and EUS also can help identify the extent of invasion into the anal canal and adjacent structures. 67 Angiography can demonstrate these lesions but seldom is necessary to establish the diagnosis. Grossly, cavernous hemangiomas appear as polypoid or mound-like reddish-purple mucosal lesions. Histologically, numerous dilated, irregular blood-filled spaces are seen within the mucosa and submucosa and sometimes extend through the muscular wall to the serosal surface. The vascular channels are lined by flat endothelial cells with flat or plump nuclei depending on their age. Younger hemangiomas have plump endothelial nuclei and often demonstrate mitotic activity, a feature not present in older lesions, vascular lumina remain small and irregular. 66 As the lesion matures, the endothelial cells flatten and decrease in number. During involution, the fibrous septa thicken, the endothelial cells are replaced by adipocytes, and the vascular structures atrophy. 66 Although lacking a capsule, the capillary hemangioma is often well circumscribed and there typically is a central feeding vessel with radiating, lobular extensions. 66 Capillary hemangiomas are plaque-like or mound-like reddish-purple lesions composed of a proliferation of fine, closely packed, newly formed capillaries separated by little stroma. The endothelial cells are large, usually hypertrophic, and in some areas may form solid cords or nodules with ill-defined capillary spaces. Small hemangiomas that are solitary or few in number and approachable endoscopically can be ablated. Most large or multiple lesions require resection of either the hemangioma alone or the involved segment of colon. Large lesions should not be ablated endoscopically unless it is first proved, e.g., by EUS, that the lesion is not transmural. Local measures to control massive bleeding from cavernous hemangioma of the rectum usually are effective only temporarily. Embolization and surgical ligation of major feeding vessels also have been used, but ultimately, excision of the rectum often is required. 68 In a particular entity known as diffuse intestinal hemangiomatoses, numerous lesions, usually of the cavernous type, involve the stomach, small bowel, and colon. Hemangiomas of the skin or soft tissues of the head and neck frequently are present. The occurrence of bleeding or anemia in childhood typically leads to the diagnosis, and surgical intervention may be required for continuous, slow bleeding or for intussusception. 69 Intraoperative endoscopy had been helpful in finding small lesions, but today SBE and DBE probably would be tried first. Inhibitors of the VEGF receptor, bevacizumab, and multi-targeted tyrosine kinases including sunitinib, inhibits VEGF, platelet-derived growth factor PDGF, vadalanib, inhibits VEGF, PDGF, c-KIT, and semaxanib, inhibits VEGF and PDGF, have been used for treatment of hemangioblastoma, another highly vascularized lesion of uncertain histogenesis that occurs most frequently in patients with von Hippel-Lindau disease, VHLD. 70 In VHLD, a loss of von Hippel-Lindau protein results in an accumulation of hypoxia-inducible factor and, subsequently, excessive production of VEGF. 71 Bevacizumab, a humanized monoclonal antibody against VEGF may, in patients with VHLD, result in stabilization or regression of CNS hemangioblastomas with resultant improvement in visual acuity in the setting of macular and optic nerve hemangioblastomas. 70. These results suggest there may be a role for the use of VEGF inhibitors in the management of other types of hemangiomas. Definitive treatment can be provided with surgery. AB vascular lesion. Pteristic phlebolith pattern outside the colon, with scalloping of the bowel lumen caused by pressure from the liths in a child is pathognomonic for a cavernous hemangioma. B. A barium enema film shows the carica soft tissue mass with foci of calcification in abnormal vascular channels. This appearance of pelvic phlebo Fig. 38.132 Imaging examples of cavernous hemangioma of the rectum. A. Plain film of the pelvis reveals Chapter 38 vascular lesions of the gastrointestinal tract. 571 Congenital arteriovenous malformation. 38 AVMs are embryonic growth defects and are considered to be developmental anomalies. Although AVMs are found mainly in the extremities, they may occur anywhere in the vascular system. In the colon they may be small and resemble EAs, or they may involve a long segment of bowel. The most extensive AVMs typically are in the rectum and sigmoid. Histologically, AVMs are persistent congenital communications between arteries and veins located primarily in the submucosa. Characteristically, there is arterialization of the veins, i.e., tortuosity, dilatation, and thick walls with smooth muscle hypertrophy and intimal thickening or sclerosis. In long-standing AVMs, the arteries are dilated and exhibit atrophic and sclerotic degeneration. Angiography is the primary means of diagnosis, Fig. 38.14. Early filling veins in small lesions and extensive dilatation of arteries or veins in large lesions are typical. Patients with significant bleeding from large AVMs should undergo resection of the involved segment. Transendoscopic therapy may be beneficial for smaller lesions. Aneurysms. Abdominal aortic aneurysm. Approximately 95% of abdominal aortic aneurysms, AAA, are atherosclerotic in origin, although genetic predisposition is also an important factor. Less common causes include trauma, vasculitis, infection, and congenital abnormalities. Risk factors associated with the development of an AAA include age older than 60 years, male gender, white race, smoking, and hypertension. Population-based studies in adults older than 50 years have found that the prevalence of AAA is 3.9% to 7.2% in men and 1.0% to 1.3% in women. 72 Familial clustering of AAA has been noted in 15% to 20% of cases, and, in some families, an abnormality has been identified in chromosome 1673. Defects in procollagen 3 in patients with Ehlers-Danlos syndrome type 4 and altered gene expression causing abnormalities of the elastin and collagen content of AAA have been shown in other families. 73. The two genes with the strongest supporting evidence to date of contribution to the genetic risk for AAA are the CDKN2BAS gene, also known as ANRAL, which encodes an antisense RNA that regulates expression of the cyclin-dependent kinase inhibitors CDKN2A and CDKN2B, and DAB2IP, which encodes an inhibitor of cell growth and survival. 74 Most AAAS are asymptomatic until rupture and are incidentally detected on abdominal US, CT, or MRI performed for other indications. As a result, current guidelines support screening with one-time abdominal US in men between the ages of 65 and 74 years who have a history of smoking. 72 The most common symptom of AAA is epigastric pain, often radiating through to the back. Severe pain may presage rupture. On physical examination, a pulsatile epigastric mass may be palpable. Distinguishing an aneurysm from an overlying abdominal mass with transmitted pulsations may be difficult on physical examination and is best done by imaging studies. A bruit may be present, but unless recent in onset, is usually of no diagnostic help. 72 Abdominal plain films may show a soft tissue mass with peripheral calcification in the region of the abdominal aorta. With large aneurysms, erosion of the lumbar vertebrae or displacement of surrounding viscera, including bowel, kidneys, and ureters, may be seen. Because plain film studies are not sufficiently sensitive to establish the presence or size of an aneurysm, US, CT, and MRI have become the standard means of evaluation. US is the imaging screening modality of choice for AAA because it is highly sensitive, 95% to 100%, and specific, 100%, and relatively inexpensive. Additionally, US is the preferred test for serial monitoring of an AAA to detect changes in its size. 72 CT and MRI are used preoperatively to demonstrate aortic and vascular anatomy and to help tailor stent grafts. Preoperative angiography is not used as frequently as in the past and is most appropriate in patients with evidence of peripheral vascular disease, severe hypertension, symptoms of chronic mesenteric ischemia, see Chapter 118, if thoracic or iliac artery involvement is suspected, and in cases of horseshoe or pelvic kidneys to demonstrate renal artery anatomy. Angiography is not used to estimate the size of the aneurysm because intraluminal laminated thrombus limits delineation of the entire lumen and, more importantly, simpler, less invasive, and less expensive imaging modalities are now readily available. The major complication of AAA is rupture, which is heralded by the sudden onset or worsening of abdominal, flank, or back pain. An insidious presentation characterized by several weeks of pain can occur when leakage precedes overt rupture. Pain may be exacerbated by lying recumbent and relieved by sitting or leaning forward. Severe abdominal pain also may be seen with aortic dissection as the splanchnic vessels become compromised and acute intestinal ischemia develops. The consensus among vascular surgeons is that the most important predictor of AAA rupture is the size of the aneurysm. The annual risk for rupture is nearly 0% for AAAS between 3.0 and 3.9 cm in diameter, 1% for those between 4.0 and 4.9 cm in diameter, and 11% for those between 5.00 and 5.99 cm in diameter. 72 Risk factors associated with rupture include hypertension and the presence of chronic obstructive pulmonary disease. AAA most commonly ruptures into the retroperitoneal tissues that surround the aorta. Less commonly, the aneurysm may communicate with the peritoneal cavity, in which case hemorrhagic shock develops rapidly. Aneurysmal rupture into the small intestine usually occurs in the third or fourth portion of the duodenum and typically presents as massive GI bleeding. Intermittent bleeding can occur with clot formation and subsequent dislodgement from the eroded bowel or fistulous opening. Indeed, many of these patients will have a herald bleed followed by massive hemorrhage several hours or days later. 75 Endoscopy is the most sensitive method for diagnosing this complication. Rarely, AAA ruptures into the inferior vena cava. If so, a loud bruit can be heard. Asymptomatic patients with an AAA larger than 5.5 cm or symptomatic patients with aneurysms of any size should undergo surgical repair to prevent rupture. Those with an AAA between 3.0 to 5.4 cm should be surveyed by US or CT every 3 to 12 Fig. 38.14 mesenteric angiogram in a patient who presented with recurrent LGIB. The angiogram shows a complex, Race-Mohs configuration of vessels in a large congenital AVM involving the superior and inferior mesenteric arterial circulations. 572 Part 4 Topics involving multiple organs. Months. 72 The growth rate of AAAS is variable and has been less in recent studies than in older ones. In a large population of patients with small aneurysms, average initial size of 4 cm, studied over an average of 3.3 years, 58.4% of patients had no change or a decrease in aneurysm size, 25.3% had an expansion between 0.1 and 0.25 cm, 12.6% had an increase of greater than 0.25 cm, and only 3.7% had an enlargement of greater than 0.5 cm. 73 On average, the growth rate of an AAA is 0.35 cm per year. Operative repair of an AAA includes an open approach either retroperitoneally or transabdominally, or an endovascular repair, which involves insertion of an endograft into the vascular lumen to exclude the aneurysm from blood flow, thus minimizing the risk of rupture. In elective cases, preoperative angiography is useful to demonstrate additional vascular disease, e.g., stenosis or occlusion of the splanchnic arteries, and allows for planned vascular reconstruction, which may help avoid postoperative bowel ischemia. The mortality of AAA repair in good risk patients is 1% to 4%. 75. Mortality increases sharply to 34% to 85% when surgery is done as an emergency for rupture or impending rupture. 76 Increasingly, endovascular aneurysm repair, EVAR, is being used as an alternative to open repair of an AAA. EVAR may provide selective short-term advantages over open surgery, such as avoidance of general anesthesia, reduced operative time, reduced blood loss, and less postoperative pain. In 3 major trials comparing open surgery with EVAR for AAAS larger than 5.5 cm, EVAR had a lower operative mortality rate than open surgery, but AAA-specific and all-cause mortality did not differ and EVAR had higher re-intervention rates. 77 Current recommendations support open repair of an AAA in patients who are at low or average risk for operative complications and EVAR in those who at high risk for complications. 77-79 EVAR also should be considered in patients who are not at high surgical risk, although evidence supporting benefit in this group is not well established. 77 Splanchnic artery aneurysms. The prevalence of splanchnic artery aneurysms, SAAS, has been estimated to be up to 10% based on autopsy reports, although the natural history of SAAS is not well understood. 80-81 SAAS are usually asymptomatic and detected incidentally on imaging studies. In a recent retrospective review from Yale New Haven Medical Center, 138 SAAS in 122 patients were documented on imaging studies from January 1999 to December 2016, and their annual growth rate and risk of rupture assessed. 81 The growth rate of SAAS was slow, 0.064 plus or minus 0.18 cm/year, and the smallest aneurysm rupture was seen at 2.3 cm, hence the recommendation to observe asymptomatic patients with SOS less than 2.5 cm. When symptomatic, SOS can present with abdominal pain or GI bleeding. On physical exam, a bruit may be heard on auscultation, but an abdominal mass is rarely palpable because the aneurysms are small. Up to 25% of SOS may be complicated by rupture, which has an estimated mortality rate of 25% to 70%. 0.82 Like aneurysms of the aorta, if a SAA erodes into the GI lumen, this can present with sporadic GI bleeding, the so-called herald bleed. Rupture into a mesenteric vein can result in an AV fistula and can lead to portal hypertension with variceal bleeding. If an SAA is sufficiently calcified, it may be seen on plain films of the abdomen, but the diagnosis is usually made with CT, MRI, or splanchnic angiography, which has the added benefit of a potential therapeutic intervention. Treatment depends on the presentation, location, and size of the aneurysm. In general, treatment is considered if the diameter of the aneurysm is greater than 2 cm even if asymptomatic. Treatment options include embolization, surgical repair, or endovascular stenting. 0.81 Embolization may be preferred for aneurysms difficult to manage surgically and for high-risk patients. Splenic artery aneurysms. Splenic artery aneurysms are usually saccular, and 20% of patients have multiple aneurysms. Symptoms if present are left upper quadrant or epigastric pain that may radiate to the left shoulder. The common causes are atherosclerosis and portal hypertension, whereas less common causes include splenic arterial dissection, septic emboli, hypertension, polyarteritis nodosa, SLE, Ehlers-Danlos syndrome, fibromuscular dysplasia, and neurofibromatosis. There is a female-to-male predominance of 3 to 4:1, and it is associated with pregnancy. 0.80-83 The increased prevalence in pregnant women may be related to an increase in splenic blood flow and the effects of estrogen on the elastic tissue of the tunica media, which can result in dilatation of the splenic artery and predispose to aneurysm formation. Similarly, increased splenic blood flow is considered the cause of splenic artery aneurysms in portal hypertension. Aneurysmal rupture occurs in less than 2% of patients except for in pregnant women in whom the risk of rupture is much higher. More than 95% of aneurysms in pregnant women are diagnosed after rupture and are associated with a 75% maternal and 95% fetal mortality rate. 0.80 If the aneurysm ruptures into the lesser sac, the patient can remain hemodynamically stable, but once the blood overflows into the greater intraperitoneal sac through the foramen of Winslow, diffuse abdominal pain and hypovolemic shock will develop. This is the double rupture phenomenon. It is said that the period in which the bleeding is localized in the lesser sac allows time for surgical intervention in about 25% of patients. 0.80 Treatment options for splenic artery aneurysms depend on the location as well as its presentation. Ruptured aneurysms are usually treated with splenectomy. Mortality after emergency surgery is as high as 40%, compared with a very low mortality rate after elective repair. A symptomatic aneurysm or an aneurysm of any size in a pregnant woman or a woman planning to get pregnant should undergo repair before pregnancy. If the location of the aneurysm is proximal and it is larger than 2 cm, surgical management should be considered and would include resection and an end-to-end vascular repair. If the location is distal or involves the hilum, splenectomy is recommended. Aneurysms between 1 and 2 cm should be monitored with imaging. If surgery is not an option, embolization may be performed. For patients with portal hypertension, embolization is preferred because the extensive collateral circulation makes surgery more difficult. Complications of embolization include splenic infarction and reperfusion of the aneurysm, which can occur in 5% to 20% of patients. Yearly follow-up imaging with CT or MRI is recommended to evaluate for leak and subsequent growth. 0.80-82 Celiac artery aneurysms. Historically, the most frequent cause of celiac artery aneurysms, CAS, was infection due to either syphilis or tuberculosis, and most cases were diagnosed at autopsy after an aneurysm ruptured. Now that syphilis and tuberculosis are more readily identified and treated, The more common causes of CA aneurysm are atherosclerosis, trauma, dissection, and Takayasu arteritis. 80,82 Association with other aneurysms is common and in one series occurred in 66% of patients. 83 CA aneurysms are usually asymptomatic. Symptoms, when present, can mimic pancreatitis due to location. Dysphagia can occur from esophageal compression. The lifetime risk of rupture is about 6%. CA aneurysms greater than 2.5 cm should be considered for repair, whereas asymptomatic lesions less than that size can be followed with imaging. 82 Traditional open repair can be performed through a transabdominal route or thoracolumbar approach. Ligation can be performed followed by aortohepatic bypass or direct aortic reimplantation. In patients undergoing revascularization, prosthetic grafts have a lower risk of occlusion than saphenous vein grafts but are difficult to place. Chapter 38 Vascular lesions of the gastrointestinal tract 573-38 due to its location. If the aneurysm ruptures, intervention may include ligation or percutaneous transcatheter embolization. 80 Superior mesenteric artery aneurysms. Superior mesenteric artery, SMA, aneurysms are rare. They usually involve the proximal 5 cm of the SMA. Aneurysm-related thrombus or dissection can occur, which can cause symptoms of intestinal ischemia. Historically, the most common etiology was infectious, with septic emboli accounting for a third of all SMA aneurysms. In recent series, the common causes include atherosclerosis, polyarteritis nodosa, pancreatitis, biliary tract disease, neurofibromatosis, and trauma. 83 More than 90% of SMA aneurysms are symptomatic with associated abdominal pain and GI bleeding. Up to 50% of the patients present with rupture and a mortality rate of 30%. Beta-adrenergic blockers can have a protective effect against rupture. 80 Intervention is recommended for all symptomatic patients and for all patients at low surgical risk because of the high rate of complications. For asymptomatic aneurysms less than 2.5 cm, surveillance is recommended. 82 The surgical approach includes aneurysmectomy and either interposition vein grafting or ligation of a branch of a mesenteric artery to treat the aneurysm. In addition, resection of any ischemic segment of bowel is performed. Transcatheter embolization and endovascular stenting can be used as well, but the latter may increase the risk of mesenteric ischemia if the branches of the SMA are blocked by the stent. Beta-adrenergic blockers should be used for individuals who are reluctant to undergo interventional procedures. 80,82 Mycotic aneurysm. Mycotic aneurysms of the aorta and splanchnic vessels are rare. They were so named by Sir William Osler because their appearance reminded him of fungi, myx, fungus. In the past, mycotic aneurysms were most commonly caused by septic emboli from bacterial endocarditis. Today the main risk factor is for drug use. Other important risk factors include contiguous spread from adjacent infectious processes, arterial manipulation, and immunocompromise, e.g., alcoholism, diabetes mellitus, chemotherapy, treatment with glucocorticoids. Salmonella, especially Salmonella choleraesuis, and Staphylococcus are the most common infecting organisms. The CA is most often affected, followed by the SMA and IMA. Early in the course, symptoms of mycotic aneurysms are nonspecific. Fever, chills, and abdominal pain typically occur later. Diagnosis is by imaging the vasculature. Mycotic aneurysms typically are lobulated and saccular, Fig 38.15. The destructive process can develop quickly, leading to rapid expansion and rupture. Treatment is surgical, usually with resection of the aneurysm and vascular reconstruction followed by 4 antibiotics for 6 weeks. Lifelong suppressive oral antibiotic therapy also has been used to prevent prosthetic graft infection. 153,154 Paraprosthetic enteric and aortoenteric fistula is an uncommon but potentially catastrophic complication of aortic aneurysmectomy and other procedures in which vascular prostheses are placed in the retroperitoneum or abdomen. Is the formation of a fistula between the graft and the adjacent bowel, usually the third or fourth portion of the duodenum because of its proximity to the infrarenal abdominal aorta, Fig 38.16, 0.84. This complication is known as a secondary aortoenteric fistula, and its frequency ranges between 0.36% and 2%. 0.85. The reported mean interval between aortic surgery and the development of a secondary aortoenteric fistula is 44 months, but such fistulas have been reported as early as 21 days and as late as 14 years postoperatively. Fistulas develop sooner, at a mean interval of 22 months, when concomitant intra-abdominal infections are present. 0.85. Secondary aortoenteric fistulas are thought to result from local conditions at the time of, or subsequent to, graft placement, including infection, damage to the duodenum or its blood supply during the dissection, and subsequent erosion of the duodenal wall by the graft. Newer surgical techniques, including the use of endovascular grafts, non-absorbable sutures, antibiotics, strict hemostasis, and coverage of suture lines with retroperitoneal tissue and peritoneum, may reduce the frequency of fistula formation. Primary aortoenteric fistulas develop in the absence of prior aneurysm repair and are associated with atherosclerosis, infection, most commonly Salmonella species and Klebsiella species. Other organisms. Fig. 38.16. Endoscopic view of the third portion of the duodenum, where part of an aortic graft is seen. Patients with aortoenteric fistulas typically present with GI bleeding, abdominal pain, and fever because the graft usually has become infected by the time it erodes into the GI tract. Courtesy, Dr. Lawrence J. Brandt, Bronx, New York. Fig. 38.15. Splanchnic angiogram of a patient with a large mycotic aneurysm of the hepatic artery. Courtesy Dr. Lawrence J. Brandt, Bronx, New York. 574. Part 4. Topics involving multiple organs that are less common include Staphylococcus species, Streptococcus species, Escherichia coli, Enterococcus faecalis, Clostridium septicum, and Lactobacillus, malignancy, radiotherapy, trauma, and foreign body. Primary aortoenteric fistulas are less common than secondary aortoenteric fistulas, with an incidence of 0.04% to 0.07%. 0.86. Patients with aortoenteric fistulas present with upper or LGIB that if untreated may be massive and rapidly fatal. EGD combined with CT imaging is used to exclude other diagnoses and plan management. 0.87. In order to make the diagnosis, a high index of suspicion is required typically in a patient who has had aortoiliac graft surgery and presents with GI bleeding, and prompt diagnosis and expedient surgical repair are essential for survival. Vascular lesions associated with systemic disorders or manifestations. Hereditary hemorrhagic telangiectasia. This autosomal dominant familial disorder, also known as Osler-Weber-Rondeau disease, is characterized by telangiectasia of the skin and mucous membranes, as well as recurrent GI bleeding. 0.88-90. In some patients, the pathogenesis follows mutations of the endoglin, ENG, and activin receptor-like kinase 1, ALK1, genes, which have an important role in determining the properties of endothelial cells during angiogenesis. 0.91. Lesions typically are noticed in the first few years of life, and recurrent epistaxis in childhood is characteristic. By age 10, about half of patients have had some GI bleeding. Severe hemorrhage is unusual before the fourth decade and has a peak incidence in the sixth decade. In most patients, bleeding presents as melena, BRBPR and hematemesis are less frequent. Hematochezia in a patient with HHT suggests bleeding from a source other than telangiectasia. Bleeding is intermittent and chronic and may be severe. Patients may receive more than 60 transfusions in a lifetime. A family history of the disease has been reported in 80% of patients with HHT, but is less common in those who bleed later in life. Telangiectasias usually are present on the lips, oral and nasopharyngeal membranes, tongue, and periungual areas. Lack of involvement of these sites casts suspicion on the diagnosis. Fig. 38.17. The diagnosis of HHT currently requires the presence of at least 3 of 4 relevant clinical criteria. These so-called Curacao criteria include epistaxis, spontaneous and recurrent nosebleeds, telangiectasias, multiple lesions at characteristic sites, e.g., lips, oral cavity, fingers, nose, visceral lesions, e.g., pulmonary, hepatic, cerebral, spinal, GI, and a positive family history, a first-degree relative with HHT, 92, clinical diagnosis can be confirmed by molecular genetic analysis. In most cases, HHT is caused by mutations in one of the two known HHT genes. Mutations of the ENG gene lead to type 1 HHT.93. The ENG gene is located on chromosome 9 and encodes for endoglin, a type 3 transforming growth factor beta, TGF-beta, receptor. Mutations of the activin gene lead to type 2 HHT. People with type 1 HHT tend to develop symptoms earlier than those with type 2 HHT and are more likely to have blood vessel malformations in the lungs and brain. Liver involvement with portal hypertension is more common in patients with type 2 HHT. The activin gene is located on chromosome 12 and encodes for the ACVRL1 protein, a type I TGF-beta receptor. 90. Both receptors are expressed predominantly on vascular endothelium and play essential roles in maintaining vascular integrity. Evidence for the existence of two other as yet unidentified HHT genes has been reported. 94,95 Mutation of the SMAD4 gene, involved in the TGF-beta signaling cascade, which is known to cause juvenile polyposis, also has been reported in a few patients with HHT. 96,97. These patients have an overlap syndrome of juvenile polyposis and HHT, and therefore are at significant risk for colorectal cancer, CRC, which necessitates aggressive CRC screening. 96 Despite genotypic heterogeneity in HHT, clinical expression of the different HHT genotypes appears similar. HHT and non-hereditary intestinal AE are both characterized by increased production of VEGF. High serum levels of VEGF, which also correlate with severity of bleeding, are found in patients with HHT. 98,99 Vascular involvement of the liver is common in HHT, especially type 2, and frequently is asymptomatic. Hepatic manifestations during the course of the disease are seen in 8% to 31% of patients and include high output heart failure resulting from AV shunting, portal hypertension, and biliary tract disease. 100,101 Liver involvement is associated with complications, including liver failure necessitating liver transplantation, and significant morbidity and mortality. 102 In one study that followed patients with HHT and known hepatic vascular malformations for a median of 44 months, 5.2% of patients died and 25.3% experienced complications, including high output heart failure, atrial fibrillation, portal hypertension, and GI bleeding. Complete response was achieved in 63% with the implementation of multidisciplinary therapy that included supportive care, medical treatment of high output heart failure and portal hypertension, radiofrequency ablation, RFA, in those who developed atrial fibrillation, transarterial embolization of hepatic vascular malformations, and orthotopic liver transplantation. 102 Telangiectasias in patients with HHT also occur in the colon but are more common in the stomach and small intestine, where they are more apt to cause major bleeding. Telangiectasias are seen easily on endoscopy, although in the presence of severe anemia, blood loss, or hypotension, they transiently may become less. ABC Fig 38.17 Telangiectasias of HHT. A. Multiple telangiectasias on the nose and lips. Telangiectasias of varying size and shape in the proximal gastric body. B. Antrum. C. From Wilcox CM Atlas of Clinical Gastrointestinal Endoscopy. Philadelphia, W. B. Saunders, 1995, p. 123. Chapter 38 Vascular lesions of the gastrointestinal tract. 575. 38 Obvious or even invisible. After correction of blood volume and blood pressure, they once again become more prominent. Evaluation by conventional angiography or newer techniques such as helical CTA 103,104 and MRA may be unrevealing or demonstrate heterogeneous enhancement of hepatic parenchyma, dilated and tortuous intrahepatic arterial branches, conglomerate masses of abnormal vessels, aneurysms, AV communications, phlebectasia, and hepatic artery and portal vein enlargement. 104,105 Angiography may be misleading when it demonstrates multiple vascular abnormalities because some of these lesions may be in the mesentery rather than in the intestine and are not potential sites of GI blood loss. Grossly, the telangiectasias of HHT are the size of millet seeds and typically appear as cherry red, smooth hillocks. Pathologically, the major changes involve the capillaries and venules, but arterioles also may be affected. Lesions consist of irregular, ectatic, tortuous blood spaces lined by a delicate single layer of endothelial cells and supported by a fine layer of fibrous connective tissue. No elastic lamina or muscular tissue is present in these vessels, so they cannot contract. This property may explain why telangiectasias tend to bleed. Arterioles show intimal proliferation and commonly have thrombi in them, suggesting vascular stasis. In contrast to the thinned venules of ES, venules are abnormally thick in HHT, have prominent, well-developed longitudinal muscles, and are thought to play a major role regulating blood flow within the telangiectasia. 103 Many forms of treatment have been recommended for telangiectasias, including estrogens 106 aminocaproic acid 107 endoscopic thermal ablation 6,47 and resection of involved bowel. Endoscopic ablation, including the use of the APC and thermal contact devices, is most promising when lesions are within reach of the endoscope and not widely diffuse. The availability of SBE and DBE, however, extends the range of endoscopic therapy to the entire GI tract. Endoscopic therapy may be performed during active bleeding or between bleeding episodes and has reduced the need for emergency bowel resection. Long-term follow-up studies are necessary to evaluate the ultimate efficacy of the various forms of therapy. Bevacizumab was used in a study of 25 patients with HHT and associated severe hepatic vascular malformations with high cardiac output. It resulted in decreased cardiac output and a reduction in epistaxis. However, liver vascularity, liver volume, and liver tests were not significantly different at the 6-month follow-up. 108 This experience was in contrast to that observed in one report of a 47-year-old woman with HHT and severe liver involvement treated 4 years earlier in whom reversal of cholestasis, resolution of cardiac failure and ascites and improvement in nutritional status was observed 3 months after initiating treatment, and a marked reduction in liver vascularity and liver volume were noted over a 6-month interval. 109 Data are still limited in regards to the use of bevacizumab for the treatment of GI bleeding in patients with HHT, but case reports and small studies have shown it to be beneficial in decreasing transfusion requirement and improving quality of life. Further research is needed to determine the optimal frequency and duration of treatment. 110-112 Blue rubber bleb nevus syndrome in 1860, an association of cutaneous vascular nevi, intestinal lesions, and GI bleeding was described, and almost a century later this constellation of findings was named Blue rubber bleb nevus syndrome, BRBNS, by Bean to distinguish it from other cutaneous vascular lesions, Fig 38.18. Other sites in addition to the GI tract may be affected, including the eyes, nasopharynx, parotid glands, lungs, liver, spleen, heart, brain, skeletal muscles, urinary bladder, and penis. Orthopedic abnormalities may be present, and calcification, thrombosis, and consumptive coagulopathy, with thrombocytopenia, may occur within the lesions. 113 A familial history is infrequent, although a few cases of autosomal dominant transmission have been reported. 114 and one analysis has identified a responsible locus on chromosome 9. A recent study hypothesized that BRBNS may be due to somatic mutations in TEC, the gene encoding TIE2, which is the endothelial cell tyrosine kinase receptor for the angiopoietins. This study found that TEC mutations were present in 15 of 17 individuals with BRBNS, supporting the hypothesis that these genetic mutations was the cause of the cutaneomucosal venous malformations. 115 The lesions are distinctive, they are blue and raised and vary from 0.1 to 5 cm in diameter. Characteristically, the contained blood can be emptied by direct pressure, leaving a wrinkled sac remaining until it fills again. Lesions may be single or numerous and are usually found on the trunk, extremities, and face. They may involve any portion of the GI tract but are most common in the small bowel. In the colon they are more common distally. They are detected infrequently by barium or angiographic studies and are seen better with CT and MRI. Endoscopy is the most important diagnostic test for this syndrome, but VCE has also been used. 116 Originally the lesions were thought to be hemangiomas, but they are now considered to be venous malformations. Resection of the involved segment of bowel is recommended for recurrent hemorrhage. APC may be dangerous because these lesions may involve the full thickness of the bowel wall. Successful sclerotherapy and band ligation of GI tract lesions have been reported. Progressive systemic sclerosis, scleroderma, telangiectasia is a prominent feature of progressive systemic sclerosis, especially in the calcinosis, Raynaud phenomenon, esophageal dysmotility, scleroderma, and telangiectasia, CREST. Variant. 117 sites most frequently involved by these lesions are the hands, lips, tongue, and face, but gastric, intestinal, and colorectal lesions have been reported. These tiny lesions may be the source of occult or clinically significant bleeding and are best treated, if possible, by endoscopic thermal ablation. 118 Klippel-Trenaunau and Parkes-Weber syndromes. In its initial description, the Klippel-Trenaunau syndrome, KTS, consisted of 1. A vascular nevus that involved the lower limb, 2. Varicose veins that were limited to the affected site and appeared at birth or in childhood, and 3. Hypertrophy of all tissues of the involved limb, especially the bones. 119 Subsequently, a variety of vascular lesions were noted to be associated with the hypertrophic limb, and some authors now divide the syndrome into two distinct types. Fig 38.18 fingertip lesion in a patient with the blue rubber bleb nevus syndrome. 576 Part 4 Topics involving multiple organs. Klippel-Trenaunau and Parkes-Weber. The former is a pure low-flow condition, whereas the latter is characterized by higher flow AV fistulas. Several genetic defects in the regulation of the angiogenic factor VG5Q have been shown in patients with KTS. 120 The cause of bony elongation is controversial, but one theory invokes in utero venous hypertension and stasis. 119 Edema of the involved leg is common, and if the thigh is involved, Fig 38.19a, a variety of lymphatic abnormalities are usually present, e.g., chylous mesenteric cysts, chyloperitoneum, protein-losing enteropathy, see Chapter 31. Visceral lesions have been described involving the GI tract, liver, spleen, bladder, kidney, lung, heart, and genital organs, see Fig 38.19b. Involvement of the GI tract is more common than previously thought and may occur in as many as 20% of patients, some of whom may not be recognized to have visceral involvement because they are asymptomatic. GI bleeding is the major symptom of visceral GI involvement and initially is intermittent, beginning in the first decade of life. Subsequently, GI bleeding from KTS may vary from occult to massive. 121 In the largest series, the most common GI symptom was hematochezia, although reported by only 6 of 588 patients. 119 The most common bleeding sites in the GI tract are the distal colon and rectum, and involvement of the whole GI tract is uncommon. 121 GI bleeding usually is caused by a rectal vascular lesion, localized rectovaginal varices resulting from obstruction of the internal iliac system, or portal hypertension with varices, see Fig 38.19c. Bleeding may be intensified by consumption coagulopathy, which may occur within the smaller sinusoids of the vascular lesion. Physical examination is diagnostic, but various imaging techniques are used to define the anatomy and plan surgical repair. 122 MRA is used for diagnosis and to detect AV shunting. 123 Angiography remains the gold standard and may allow for therapeutic intervention. 121 Endoscopic thermal ablation therapy is useful in controlling hemorrhage and preventing or minimizing recurrent GI bleeding, especially when the lesions are relatively well localized. L. Brandt, personal experience, however. Patients with clinically significant hemorrhage often require surgical resection. 121 Radiation-induced mucosal injury. Radiation injury can induce a progressive obliterative endarteritis and endothelial proliferation leading to neovascularization and telangiectasia formation which may bleed. 124 As discussed in Chapter 41, radiation injury can occur anywhere in the GI tract but is most commonly described in the rectosigmoid as a result of pelvic radiation for prostate and cervical cancers. 125,126 GAVE, watermelon stomach, and portal hypertensive gastropathy, enteropathy, and colopathy. GAVE, watermelon stomach, describes a vascular lesion of the gastric antrum that consists of tortuous, dilated vessels radiating outward from the pylorus like the spokes of a wheel and resembling the dark stripes on the surface of a watermelon. 127 This lesion may cause acute hemorrhage, chronic occult bleeding, or both. Its cause is unknown, although it has been proposed that gastric peristalsis causes prolapse of the loose antral mucosa with consequent elongation of the mucosal vessels. Fig 38.20, 127,128 GAVE also has been postulated to result from delayed gastric emptying, as well as from hypergastrinemia, prostaglandin E2, 5-hydroxytryptamine, serotonin, and vasoactive intestinal polypeptide. GAVE is seen particularly in middle-aged or older women and in association with achlorhydria/atrophic gastritis, cirrhosis, and portal hypertension, chronic kidney disease, cardiac diseases, autoimmune and connective tissue disorders, as well as after bone marrow transplantation. 117, 129, 130 The association with cirrhosis and portal hypertension is seen in approximately 40% of reported ABC. Fig 38.19 Images of Klippel-Trenaunah syndrome. A. Edema of the involved leg and associated vascular lesions are seen. B. Involvement of the scrotum in another patient. C. Endoscopic image of the same patient in B showing an example of extensive rectal vascular lesions that can be a cause of GI bleeding. Courtesy, Drive. Lawrence J. Brandt, Bronx, New York. Fig 38.20 Endoscopic appearance of GAVE, also referred to as watermelon stomach. Chapter 38 Vascular lesions of the gastrointestinal tract. 577 38 cases of GAVE, thus, GAVE may be caused by portal hypertension or hepatic veno-occlusive disease. 131 Although GAVE may not respond to therapies directed at reducing portal pressure. Given case reports of GAVE resolution after liver transplantation, however, it is possible that hepatic insufficiency may play a role in its pathophysiology. 132 Although not pathognomonic, microscopic features of GAVE include mucosal capillary ectasia and congestion, focal thrombosis, spindle cell proliferation, smooth muscle cell and myofibroblast hyperplasia, and fibrohyalinosis that surrounds the ectatic capillaries of the lamina propria. 130 Some researchers believe that GAVE and portal hypertensive gastropathy, PHG, are different manifestations of the same pathogenetic process, but the literature suggests that these are distinct entities. 133 And distinguishing them is important in order to implement appropriate therapeutic intervention. 130 Limited pharmacotherapy options are available for treating GAVE. Estrogen progesterone has been tried 134 and appears to have some efficacy. Successful use of tranexamic acid, an antifibrinolytic agent. 135, 136 and thalidomide 137 also have been reported. In a randomized controlled trial, thalidomide was found to markedly reduce recurrent bleeding in patients with GAVE and other GI angiodysplasia. 138 TIPS does not appear to be effective for GAVE in the absence of portal hypertension. 139 Antrectomy has been a last resort for patients in whom pharmacologic and endoscopic therapies have failed. 140 Transendoscopic therapy is the current mainstay of management for GAVE. Multiple studies have shown that APC improves anemia and decreases transfusion requirement, particularly in cirrhotic patients. Side effects are minimal, although multiple treatments are usually needed. Band ligation also has been shown to be helpful in retrospective studies. Other therapies that can be considered if APC is not available include RFA, cryotherapy, and the use of cyanoacrylate spray. 141 Portal hypertension in a patient with GAVE and GI bleeding makes the bleeding more difficult to manage because bleeding is usually greater and more resistant to treatment in this situation. 142 Several case reports have detailed reversal of GAVE after liver transplantation. 143 However, the data are insufficient to recommend this therapy unless the patient is otherwise a liver transplant candidate. TIPS offers another modality when GAVE is associated with portal hypertension or when bleeding resulting from GAVE associated with PHG cannot controlled endoscopically. See also chapters 20 and 92. Portal hypertensive gastropathy, PHG, enteropathy, and colopathy. The prevalence of PHG in patients with cirrhosis varies from 20% to 98%, likely due to lack of uniform diagnostic criteria and classification. In general, there is an association with more severe portal hypertension. Patients with PHG can be asymptomatic or exhibit symptoms related to chronic GI bleeding, which has been reported to occur in 3% to 60% of patients. Acute GI bleeding is less common, with the prevalence reported between 2% and 12%. 144 PHG manifests three endoscopic patterns: 1. Fine red speckling of the mucosa, 2. Superficial reddening, especially at the tips of the gastric rugae, and, most commonly, 3. The presence of a mosaic pattern with red spots, snakeskin appearance, in the gastric fundus or body, Fig. 38.21. Histologically, PHG occurs in oxyntic mucosa and manifests with dilated, tortuous, irregular veins without fibrin thrombi, sometimes with intimal thickening, and usually in the absence of significant inflammation. 132 Management of PHG is focused on the reduction of portal pressures mostly with pharmacotherapy. Non-selective beta-adrenergic blockers are first-line therapy. Propranolol is a non-selective beta blocker that was investigated in the classic randomized controlled trial evaluating the role of beta blockade in preventing recurrent bleeding in severe PHG. 144 In this study, patients who received propranolol had a significantly lower rebleeding rate at 12 months, 35% versus 62%, and at 30 months, 48% versus 93%, compared with patients taking placebo. If a patient is refractory to beta blocker therapy, TIPS is indicated and has been effective in most cases. 140,145-147 Somatostatin analogues such as octreotide, which are established as effective treatment for acute variceal bleeding, also have been shown to be effective for acute bleeding from PHG. In two studies that evaluated the effect of these vasoactive drugs in acute hemorrhage from PHG, 148,149 bleeding was successfully treated in all patients who received somatostatin or octreotide. Vasopressin and its analog, terlipressin, also have been tried, with mixed results. 148,150 varices and spider-like telangiectasias also may be seen in the small intestine, warranting the term portal enteropathy. Portal colopathy is the term used to describe the vascular manifestations of portal hypertension in the colon, which include hemorrhoids, varices, and spider-like telangiectasias, Fig. 38.22a and 38.22b. Mucosal lesions of portal colopathy endoscopically resemble those seen in PHG and may have a diffuse, colitis-like appearance, including erythema, telangiectasia, and friability. Histologic changes of portal colopathy and enteropathy are similar to those of portal gastropathy. 151 The lesions of portal enteropathy and colopathy are amenable to the same thermal therapies used for GAVE and PHG, so long as they are within reach of the endoscope. 152 Anatomic abnormalities of the vasculature superior mesenteric artery, SMA, syndrome. The third portion of the duodenum is cradled in an angle of approximately 45 degrees formed by the root of the SMA and the wall of the aorta. When this angle is narrowed to less than 25 degrees, the SMA impinges on the duodenum, thereby leading to gastric and intestinal obstruction, a condition referred to as Wilkie's syndrome or the SMA syndrome, Fig. 38.23. 155,156 The latter term may be confusing and does not imply vascular insufficiency. Symptoms may be acute or chronic and typically include epigastric pain, vomiting, and early satiety. The syndrome has been associated with immobilization in a body cast, rapid growth in children, and marked, rapid weight loss in adults, particularly young women with eating disorders, see Chapter 9. Rarely, anatomic anomalies predispose to the condition, including a high ligament of Treitz or low origin of the SMA. Barium studies may show an abrupt cutoff in the third portion of the duodenum with dilatation proximally, particularly when the patient is supine. CTA and MRA can provide non-invasive and detailed anatomic information that can be used to diagnose the condition and plan a surgical approach. 157,158 Symptoms typically improve after restoration of lost weight or removal of a body cast. Surgery is necessary only rarely. Duodenojejunectomy may relieve the symptoms and has been performed for this condition. Laparoscopic. 159 Celiac axis compression, median arcuate ligament syndrome. Whether celiac axis compression syndrome, CACS, is a cause of GI ischemia has been a subject of controversy ever since postprandial pain and an epigastric bruit were described in a patient in whom angiography showed narrowing of the CA caused by compression from a fibrotic celiac ganglion. 160 After release of the artery, the murmur and postprandial pain disappeared. Since that description in 1963 by Harjula, compression of the CA by the median arcuate ligament of the diaphragm and the celiac ganglion has been increasingly identified but still is not well understood. 578 Part 4 Topics involving multiple organs. ABC Fig 38.21 Portal hypertensive gastropathy. A. Mild gastropathy is manifested by prominence of the areae gastricae, with areas of erythema and subepithelial hemorrhage. This appearance is not pathognomonic and may be noted with other disorders that induce mucosal edema, such as Helicobacter pylori gastritis. B. Severe gastropathy with diffuse subepithelial hemorrhage in a snakeskin pattern. C. Low-power photomicrograph showing prominent edema of the mucosa involving the lamina propria with multiple congested blood vessels. No histologic evidence of gastritis is seen. From Wilcox CM Atlas of Clinical Gastrointestinal Endoscopy. Philadelphia, W. B. Saunders, 1995, p. 109. Of a patient with cirrhosis and portal hypertension. Courtesy Dr. Lawrence J. Brandt, Bronx, New York. Spider-like telangiectasia or AE is seen in the rectosigmoid. B. Patchy foci of erythema in the descending colon. Fig 38.22 Endoscopic images showing two examples of portal colopathy. A. A solitary lesion that resembles a Chapter 38 vascular lesions of the gastrointestinal tract. 579-38 A major difficulty in determining the validity of CACS as an entity, also sometimes referred to as Harjula syndrome or Dunbar syndrome, arises from the different criteria used by various investigators to define it. 161,162 The clinical features that should be present to diagnose CACS include postprandial epigastric pain, diarrhea, weight loss, and an abdominal bruit that intensifies with deep expiration when the CA ascends more than the diaphragm and compression of the artery is increased. Compression of the CA is demonstrated by lateral aortography or selective studies of the CAEUS, CTA, and MRA are non-invasive means of demonstrating the vascular anatomy and CA compression. 163 Compression by the crural fibers of the diaphragm or the celiac ganglion produces a smooth, asymmetrical narrowing of the superior aspect of the CA and displaces it toward the SMA. Fig 38.24. These findings are best shown at end expiration and not end inspiration, which is the phase in which respiration is typically halted during angiographic studies. The clinical significance of a narrowed CA on angiography has been questioned because the finding is nonspecific and occurs with equal frequency in patients suspected of having intestinal angina, those with GI diseases not primarily characterized by pain, and those with alternative diagnoses that do not involve the GI tract. The pain that characterizes CACS is most frequently attributed to ischemia because the implicated anatomic lesion in this syndrome is narrowing of the major artery that perfuses the upper abdominal viscera. This concept has persisted, despite clinical and experimental evidence that isolated compromise of the CA is almost always compensated by collateral circulation from either the SMA or the IMA. A popular alternative theory to that of ischemia is that the pain arises in the celiac ganglion itself, possibly secondary to pressure or throbbing by the compressed artery. The increased splanchnic blood flow and dilatation of the artery that accompany the ingestion of food may explain the relationship of pain to meals. Operative approaches to CACS include division of the median arcuate ligament, with or without ganglionectomy, arterial reconstruction, or bypass. A laparoscopic approach has been successful in releasing the compression. 163 Results of operations for CACS have varied as much as have the criteria used to diagnose them. In a long-term follow-up study of patients treated for CACS, Evans found that 83% of patients were asymptomatic 6 months after a decompression procedure, but only 41% remained asymptomatic 3 to 11 years later. 164 In another study of 400 patients who underwent either open or laparoscopic division of the median arcuate ligament for the treatment of CACS, immediate postoperative symptom relief was reported in 85% and 96%, respectively. Symptom recurrence was reported in 6.8% and 5.7% of patients in the open and laparoscopic groups, respectively, when these patients were followed for 6 to 229 months after surgery. 165 The controversy concerning CACS continues. A small number of patients who have otherwise unexplained abdominal pain not helped by standard regimens have exhibited relief by some aspect of the operations performed for CACS. 166 In order to keep unnecessary procedures to a minimum, surgery should be performed only in patients who manifest the clinical features described earlier.